Next, we're going to look at factors influencing breathing rate and depth, specifically at higher brain centers. So the higher brain centers include the hypothalamus and the cerebral cortex. So those are the hypothalamic controls and the cortical controls. The hypothalamic controls act through the limbic system to modify respiratory rate and depth. An example would be holding your breath when you're angry or gasping with pain. This would be a type of involuntary breath holding. The cortical controls would use direct signals that come from the gray matter or outer part of the cerebral cortex, specifically from the motor cortex. They would bypass the brainstem respiratory centers or bypass the medullary controls, and they would go straight to the respiratory muscles, including the diaphragm and the external intercostals. Cortical controls are an example of voluntary breath holding. One example would be holding your breath until CO2 builds up in your blood so much that it reinstates breathing involuntarily. Pulmonary irritant reflexes are talking about receptors that are inside bronchioles or part of the conducting zone, and they respond to irritants. Irritants such as dust or pet dander or even pieces of accumulated mucus or even a noxious fume can cause these irritant reflexes to be set off. In the trachea or bronchi, an irritant may cause a cough, but in the nasal cavity, an irritant may cause a sneeze. But these receptors are able to communicate with respiratory centers in the brainstem via vagal nerve afferents, afferents being signals that arrive or go to the central nervous system. The inflation reflex is also known as the Herring-Brewer reflex, or the very simply inflation reflex is a lot easier, but the Herring-Brewer reflex is just stretch receptors that we find in the pleurae and some of the airways, and they're going to be stimulated when the lungs inflate. So when the lungs inflate, that information is sent to the medullary respiratory centers, and that lets the medullary respiratory centers know that inspiration did occur when the inspiratory muscles contracted. That means that volume increased, and we got stretching not only of the thoracic cage, but of the lungs themselves. We think this can work to end inhalation and allow for expiration, but it's not necessarily needed. It's more of a protective response to make sure that expiration occurs, so it's a regulatory mechanism. Here are areas showing the different neural and chemical influences on the brainstem. We can see that there's stretch receptors, there's chemoreceptors, there's higher brain centers, and all of these are going to be able to help regulate respiratory rate and depth. Specifically, this schematic diagram basically summarizes the relationships between higher brain centers, respiratory centers, and various receptors throughout the body. So all of them are going to act by influencing the respiratory centers in the medulla and the pons. So if you start at the top of the diagram of the brain, the location of the higher brain centers, the cerebral cortex is exerting voluntary control over breathing, and that would be with both excitatory and inhibitory influences on the respiratory centers. Then other receptors such as pain receptors, emotional stimuli receptors that you'd find in the limbic system, they can act via the hypothalamus to exert excitatory or inhibitory effects. And then the peripheral chemoreceptors in the aortic arch, they would have excitatory effects on the respiratory centers, but only by detecting decreasing oxygen, increasing carbon dioxide, or increasing hydrogen ion concentration levels. And then the stretch reflexes or stretch receptors, however, in the lungs, they would exert inhibitory effects on inspiration to cause expiration. And then receptors in muscles and joints, they have some excitatory effects. We have the irritant receptors as well. Those are in the lungs, in the trachea, and they would have inhibitory effects on inspiration. So this is a great study image, but it's talking about all of the influences on the brainstem, specifically those respiratory centers that control or change respiratory rate and depth. Next, we'll move on and look at what does exercise do to respiratory rate and depth. During exercise, there are adjustments that are changed and geared for both whatever the intensity and duration of the exercise is going to be. Hyperpnea is increased ventilation, and that occurs during exercise. Ventilation can actually increase up to 20-fold, and it increases quickly, then it'll gradually kind of reach a plateau, and then when you stop exercising, it will abruptly stop. So that abrupt decline in ventilation is usually followed by a gradual decline in some of the chemicals that we monitor for respiratory rate and depth. You would see after stopping exercise a decrease in the partial pressure of CO2, leaving tissues, and we would see a decrease in the partial pressure of oxygen because when you are exercising, increased ventilation does occur, and pH would remain relatively the same, but during the exercise, these amounts actually stay pretty stable. It's only afterwards that we start to see them shift to go back to normal eupnea or normal breathing. So abrupt increase in ventilation that occurs as exercise begins involves three neural factors. One is anticipating the exercise, so your body prepares for this increase in ventilation. Then the higher brain centers, such as the cerebral cortex, will communicate information from the motor cortex to the expiratory muscles and skeletal muscles of your body. It'll then also make sure that it runs all this information by the medullary respiratory centers. And the medullary respiratory centers will then send excitatory impulses to proprioceptors in your joints, tendons, and muscles. And again, this will be a gradual increase. At first, it's quite abrupt, then it will plateau. And then until you stop exercising, we won't see that abrupt decline in pulmonary ventilation. So it does decline suddenly when you stop exercising. That pulmonary ventilation does, and it's just because those three neural factors shut off, and they shut off rather abruptly. So after that, there's a more gradual decline, but at first it's abrupt, and eventually we'll see that there's a decline in carbon dioxide flow after exercise ends, because if tissues are not constantly performing increased metabolism to keep up with exercise, they'll stop producing as much CO2, or that rate of production will decline. And exercise can also lead to anaerobic respiration, specifically of muscles, that when contracted severely are unable to get rid of lactic acid or unable to use oxygen and therefore produce lactic acid. And that lack of oxygen in muscles is not necessarily indicative of poor respiratory functions. It could be because of insufficient cardiac output, but maybe it's just because the duration or intensity of the exercise was too much. Next, we want to start to look at some homeostatic imbalances or some clinical aspects to changes in altitude or disorders that can affect the respiratory system. So first, we'll just look at a change in altitude. If you quickly travel from a low to a high altitude, so say suddenly above 2,400 meters or 8,000 feet, this could trigger symptoms called acute mountain sickness or AMS. And this is because atmospheric pressure or partial pressure of oxygen would be reduced at these high elevations. Symptoms could be headache, shortness of breath, nausea, and dizziness. Not all of these have to present, but severe cases of acute mountain sickness can actually cause cerebral and pulmonary edema that is lethal. Edema being swelling in the lungs or around the lungs and around the brain for cerebral. If you slowly move up to a high elevation, meaning maybe don't immediately move up 8,000 feet, then there is an acclimatization step that can occur. Both the respiratory and the hematopoietic tissues will adjust certain functions and characteristics of your body in order to make up for this new altitude and reduce partial pressure of oxygen in the atmosphere. What we see is the chemoreceptors become really sensitive to the partial pressure of carbon dioxide. We start to see that the decline in partial pressure of oxygen in the atmosphere makes the peripheral receptors even more receptive, even to further declines in the partial pressure of oxygen. And this will increase minute ventilation for a period of time, so it'll increase the normal breathing depth and rate, or eupnea, in the individual that is trying to acclimatize or has moved to a higher altitude and their body is trying to compensate. The hematopoietic tissues will trigger or tell the kidneys to produce erythropoietin. Erythropoietin is a hormone that increases red blood cell production, and those red blood cell numbers, when they increase, will provide long-term compensation and ensure better hemoglobin saturation levels at this new higher altitude. Next, we'll look at pulmonary disorders. We'll start with a group of diseases that are considered chronic obstructive pulmonary diseases. And this is best exemplified by the diseases emphysema and bronchitis. And a key feature of these is decreased ability to force air out of the lungs. So these tend to be obstructive disorders, hence the name COPD. Common features, really symptoms of COPD, are individuals who suffer from these obstructive diseases tend to have a history of smoking. You see 80% of patients tend to have a history of smoking. It's not all, but it is a majority. Dyspnea or labored breathing, so air hunger, difficulty breathing is common in individuals with COPD. Coughing, frequent pulmonary infections, mucus buildup, and hypoventilation are all common in those who suffer from this obstructive disease. Hypoventilation can cause a buildup of CO2 or CO2 retention in the blood, so it also results in respiratory acidosis, and hypoxemia is another symptom of COPD, meaning that we see tissues that start to become cyanotic because they're not getting enough oxygen from the blood. We'll look at emphysema and chronic bronchitis separately. So emphysema is permanent enlargement of the alveoli. This will cause a decrease in alveolar surface area. It also decreases lung elasticity because the elastic tissue around the lungs can also sometimes be affected. In individuals who have progressed emphysema, they will have to use accessory muscles in order for breathing, both accessory inspiratory and expiratory muscles. This leads to exhaustion because more ATP is needed to contract these accessory muscles of breathing. And also, air can become trapped in these hyperinflated lungs. Because of the destruction, it may get trapped in destroyed alveoli, and that can flatten or push on the diaphragm and cause it to become malformed. Often individuals with emphysema may present with a barrel chest or an expanded thoracic cavity, and that's definitely going to reduce ventilation efficiency. It also makes it even harder for them to expire. And then damaged pulmonary capillaries are usually going to result in the later stages of emphysema and can lead to an enlarged right ventricle. And there are some hereditary factors for this disease. Alpha-1 antitrypsin is a deficiency that can cause the development of COPD and isn't necessarily linked to smoking. Chronic bronchitis can be caused by inhaled irritants that over time cause chronic excessive mucus buildup. The mucosae of the lower respiratory passageways then becomes inflamed and fibrosed. Fibrosed tissue is scar tissue, so it no longer responds like it's supposed to. It may not vasoconstrict, it may not bronchodilate or constrict like it's supposed to. And so that would lead to obstructed airways. It could lead to alveolar dead space because air gets trapped in these alveoli that are no longer able to participate in pulmonary ventilation. But it definitely impairs gas exchange. So symptoms include frequent pulmonary infections, just like with emphysema. Risk factors, also smoking, just like with emphysema. But environmental pollutants, which some people have no control over the environment that they must be in on a day-to-day basis, those can be a risk factor for the development of chronic bronchitis. To treat COPD, we often will give individuals treatments that treat really the symptoms. There's no cure for chronic obstructive pulmonary disease. So bronchodilators to enlarge or dilate bronchioles, corticosteroids to treat inflammation, oxygen to get rid of some of that dyspnea or air hunger, even lung volume retraction or reduction surgery. Those can all be treatments, but we're really just treating the symptoms. We're trying to get rid of inflammation, get rid of air hunger, make sure that it's easier to expire and inspire. And what we see most of the time that is two different patient categories for those who suffer from chronic obstructive pulmonary disease, or COPD. And those two categories are pink puffers and blue bloaters. Pink puffers usually have normal blood gases because they're trying so hard to breathe. They try so hard to breathe that they're usually really thin because they're using accessory muscles to breathe in and out. They're using more ATP, so they may be exhausted, but they have normal blood gases. Now, their skin color is normally pretty normal, but it may also be slightly red or look like they have increased hyperemia all over their body because using excess energy in those muscles does cause heat to build up, and so they could be slightly pink, hence the name pink puffers. Blue bloaters are usually stocky. They usually appear at least slightly obese. They may have cyanotic tissue or have a slightly bluish hue. And they definitely suffer from hypoxia. They are not able to maintain normal blood gases. Usually these individuals are the ones who need the most oxygen therapy, and they get the blue from the fact that they have that bluish hue from the cyanotic tissue. And they often are also the ones that have barrel chests. So blue bloaters are stocky because of their barrel chest. That usually result from emphysema. Treatments again are bronchodilators, corticosteroids, oxygen, but you got to be careful with oxygen. It must be administered carefully because too much pure oxygen can be toxic and produce free radicals, which can damage DNA, which could only worsen this patient's outlook. This image is just showing you the pathogenesis for COPD. It's showing you some of the risk factors or some of the reasons someone may develop either chronic bronchitis or emphysema, including smoking, air pollution, or that alpha-1 antitrypsin deficiency. And whether it's continual bronchial irritation and inflammation or the breakdown of lung tissue, including those alveolar spaces, reducing that alveolar surface area, the diseases associated with chronic obstructive pulmonary disorder have similar symptoms and treatments. There would be airway obstruction, trapped air, difficulty breathing or air hunger, and frequent pulmonary infections are common in those with COPD. Hypoventilation, meaning also hypercapnia and the buildup of CO2 in the blood, difficulty getting oxygen to tissues, and the buildup of hydrogen ions in the blood are common in those who suffer from COPD, whether it's chronic bronchitis or emphysema. We'll also look at asthma. Asthma is sometimes classified as a type of COPD. If anything, it's temporary COPD. The episodes are acute, they're not chronic like we see in COPD. There are symptom-free periods for those who suffer from asthma, but symptoms will be similar: coughing, difficulty breathing, dyspnea, therefore wheezing, chest tightness. Usually active inflammation, again, is acute, but it precedes with strong bronchospasms. Usually some type of irritant causes asthmatic attacks, and these bronchospasms called bronchial constriction, which traps air and makes it difficult to perform adequate pulmonary ventilation. The airways may thicken not only with exudate, which is protein-free mucus, but also because of inflammatory molecules that are activated, such as interleukins, production of immunoglobulin E, and even inflammatory cells. And then we have tuberculosis, an infectious disease caused by bacteria. The bacterium is Mycobacterium tuberculosis. Symptoms kind of like the flu: fever, night sweats, cough. But coughing up blood and weight loss are symptoms we see for tuberculosis that are more serious than just the normal flu. It also has a long treatment period, up to 12 months for a course of antibiotics in order to get rid of TB. And there's antibiotic-resistant strains that have been seen. And a lot of complications can result even after tuberculosis have been treated, especially if any of the lung tissue has become fibrosed or is no longer functional, has been damaged. And then last but not least, lung cancer. Lung cancer is our last homeostatic imbalance we'll look at. It's the leading cause of cancer deaths in North America. So most of the cases are going to be resultant from smoking. The three types are adenocarcinoma, squamous cell carcinoma, and small cell carcinoma. You see here that most cases are adenocarcinoma. The treatment for lung cancer depends on when it's detected, because early detection is key for survival. If it has spread, we would also use radiation and chemotherapy to treat it. If there has been no metastasis, no spreading, therefore it hasn't moved to any other part of the body, we could just remove the diseased lung tissue. There are several new therapies on the horizon, things like immunotherapies and other targeted therapies. And then, not necessarily a homeostatic imbalance, but a condition we've mentioned already, so not new. Sleep apnea is a common disorder characterized by that temporary cessation of breathing. Sometimes it has to do with decreased levels of carbon dioxide in the blood. So hypocapnia is one causative factor. And the person who has sleep apnea is normally not aware of the problem. It can make someone sleepy during the daytime, make them kind of groggy, maybe grumpy, just because they're not getting enough sleep at night. They can wake up several times each night, up to 30 times per hour, and they're not going to get constructive and restructive sleep. Obstructive sleep apnea is when the pharynx collapses, when someone breathes out, that is causing obstruction, and it'll wake them up slightly in order to kind of reopen that pharynx and breathe in. Central sleep apnea is caused by a reduced drive from the respiratory centers of the brainstem. So reduced stimulus from the medullary respiratory centers can cause central sleep apnea. The causes of disrupted sleep can lead to accidents by those who are sleepy after not getting enough sleep because they've woken up a lot of times. It can also cause chronic illness, hypertension, heart disease, stroke, and diabetes, because sleep is important for the restorative processes of your body. Obstructive sleep apnea can be treated using a CPAP machine, which stands for Continuous Positive Airway Pressure Device. And it's a mask that you put over your mouth, and it is important to clean them, but a CPAP would hold your airway open, preventing that pharyngeal collapse. And that is it for our respiratory system Part C. So make sure to view all 3 videos for Part C and review also information from Chapter 19 and 20 for your upcoming exam.